You probably know most of our panelists here from the hand division, Rashard Dacus, Nicole Deal, pretty sure you know Bobby Chabra. And then our newest addition is Casey Peak, who just joined us 6.5 months ago. And then maybe to their detriment, somehow we ended up with Lance Brunton and Erica Taylor sitting at the end of the panel. So may or may not be called upon to opine on various things. So we are going to talk about a couple of different topics. We'll get through whatever we get through here. Some general sort of updates about these things, and with a little bit of a bent towards what do you do about these issues in high-level athletes, and how do you get them back to playing as well? But at the same time, those concepts apply to just your regular patients as well. This is why we're talking about this. But as you can see, some of the injuries that you see in professional athletes, and you see 3 out of the 4 of the things we're talking about are on that list and pretty substantial. Let's see here. All right. So first topic, we're going to talk about scaphoid. Like Bobby said, we do things a little bit differently than the rest of the groups. We're going to do this case-based, and I invite any comments from the audience if you have something to add. All right. So this first one, this is a 20-year-old male athlete. These are the X-rays. Presents, a couple days after having an injury. I've included the X-rays here and then some MRIs. I don't know if Shard, do you want to start off on this one?
Me to describe what I'm seeing.
Talk about kind of, yes.
I mean,
yeah, sorry.
This
is an AP X-ray of a
all right. First of all, I wanted to comment to Dr. Zura that I'm a Tulane alum. We're the highest ranked football team this year in the state of Louisiana. Side talk. So non-displaced scaphoid fracture, some of it, a lot depends on the person, the timing. Obviously, a 20-year-old healthy person can heal without a cast, or heal in a cast. In season versus out of season, obviously, is dictated by that as well. Tolerance to cast is also dictated. This is an orthopedic resident, they would get a screw. If this was me, I'd get a screw. Most people in the room probably get a screw unless you were not practicing. I think in this individual, as an athlete, likely screw placement, center alignments, non-displaced, and then probably recheck, CT scan usually at 6 weeks. It's kind of the protocol we use here. And if it's healed, then progress. With the screw in, they can usually participate in a cast, potentially in a splint at some point as well. So that's kind of usually our algorithm, I think.
Change based on where that fracture line is, athlete versus non-athlete.
I think a proximal pull is obviously a no-brainer for surgery. A distal pull, I think you're more inclined to think about non-op.
In an athlete as well, distal pull still.
Yeah, I think the risk reward kind of goes in a different place. Distal pull, yeah, you can do some damage. So,
Daisy, you want to comment? Approach scaphoid fractures.
Yeah, I think my preference for most of these, unless it is a distal pull, is that I'll go dorsal. I just think it's easier to get your start. You can see a lot better, and I personally hate doing a volar perk screw. Your trapezium's always in the way, and everyone tells you there's lots of tricks for running the drill as a reamer, taking a little bite out of it with rongeur, and then it's not perk anymore. And I think it's just a bigger pain than it's worth. And so I tend to go with a dorsal approach for those. And I would do the mini open approach that, I don't know, somebody described it, right? I don't know. And I think that's pretty, I think that going percutaneous, some people do that, but it's pretty clear that you're going to end up injuring a tendon at some point if you do it percutaneously. So a mini open through a dorsal.
Anything to add to
that? And then I'll pass it over to Dad. I would say I agree with you, Casey. I would use 2 screws and just do that in all my scaphoids at this point in time. I just like the fixation, and they've been shown to have better strength. So that's the only thing I would add, is I would just use 2 screws. And I don't take care of collegiate or professional athletes, so I'll defer to these guys on return to play and all that jazz.
So yeah, I think the standard of care is a single screws, but there's a trend now, and we are the first ones that put it out there in the literature for acute fractures in high-level athletes, is to use 2 screw fixation, and there's enough biomechanical study and support for that. You can rehab. The healing rates are faster with screw fixation for these type of fractures compared to cast immobilization, but they both tend to heal. So you got to look at the patient and their expectations. And for this was one of our UVA basketball players, so a lot of expectations, and return to play is important, and accelerated return to play. But what's most critical is that if you return them to play, you have to make sure they don't have any long-term sequelae, because you return them to play too fast, or you didn't have enough fixation, or you didn't allow them to heal before you started letting them play, because a scaphoid non-union is a devastating complication in someone like this who has tremendous future potential.
Immobilization after surgery.
So if I used 2 screws for an acute fracture, I would put them in a splint for about 10 days and sutures out, and then put them in a removable brace and start motion, because that's the benefit of rigid fixation. For any hand fracture, you want to be able to move them quickly. And I think with 1 screw for scaphoid, the issue was always rotational instability that could lead to non-union. So 2 screws actually takes that out of the equation and allows you to rehab them faster and more safely. And we're talking about acute, waist fractures, not necessarily. Proximal pole is a different scenario with AVN, high risk of AVN. So accelerating those patients to return to play is I would do much more cautiously. But a waist, I think, removable brace pretty quickly.
And I think the other is the sport and the position. So offensive linemen, they play in casts, wide receivers can't. Basketball is different than football in a lot of ways. So if I fixed one in a football player, I'd let him play in a cast. I'd let him wear a brace otherwise, but play in a cast. And so some of that is based on their position.
So this is the case we were just talking about. So they got 2 screws. You can see kind of parallel screws depending on which plane, but you can fill up the scaphoid pretty nicely. Still have enough bone for it to heal, giving good stability. There's enough hand surgeons in the room, I think. Perhaps screws, plates. Anybody? Just
Lance and Erica. Yeah.
So I just had this case, but a little different. It's a football player somewhere in this region, but he was 7 months out, non-union. I did what you all taught me to do, a distal radius cortical window, got some cancellous graft and put it in through a volar approach. Went in pretty nicely, but at Duke, sorry about that. At Duke,
turn off the mic.
people, no, we're doing mostly like mini and a micro screw, the 2 screw technique for sure. So, but in this case, the non-union athlete, I'm putting him in a cast. He's off season right now.
When you put in those 2 screws, do you say it like we do at UVA?
It doesn't quite sound the same. Here you go.
He's loud enough.
The only concern that I have is that some of these fractures are not perfectly transverse. And so one of my premises of internal fixation on the scaphoid is trying to be as perpendicular to the fracture plane as possible, which sometimes precludes you from being able to use 2 implants. And also the variations in the scaphoid morphology, which is that some are a little more narrow in the center than others. And I think you have to account for that, not necessarily go into your surgical treatment plan expecting to do this, but only if it accommodates it.
I think that's a good point. Sometimes it just doesn't fit. All right, good. So just an article out there talking about scaphoid fractures and the return and why we fix them versus treating them non-operatively as well. Another biomechanical study alluding to what Dr. Charles was talking about in terms of the stability that you get from the different patterns, and 2 screws tends to be stiffer, and you do get rotational control. So there's some advantages, disadvantages. Obviously, not every scaphoid fits 2 screws. All right, move on to the next one here. So more like the one you were talking about, but so another athlete, 6 months plus perhaps, no examination, and then found out to have this fracture here.
Yeah, so this is looking like a non-union. You can see that he's got that cystic change, and it's a more proximal waist. And then that looks like it's extending into the proximal pole. And looking at that CT scan, a little bit more concerned about the sclerosis that's happening in that proximal pole. And now we're starting to develop a humpback deformity too, and kind of heading into DZ. So this looks just like a more complex situation where you're going to have to open it up and get into the fracture site, debride it a lot. And I'd have some concern about the perfusion to that proximal pole at this point. I think that there's pretty reasonable literature to support that you could try to just open this up, cancellous graft it, and see if it heals. But we're also dealing with an athlete, and I think that that's where the discussion has to happen about how willing are we to give this a chance in kind of the normal way, and then come back and do some kind of vascularized graft later on. And I think this is a more complex discussion that we have all the time about these fractures. Where you think about maybe doing like a 4-5 ECRA or something like that. And I think that's where patient-centered care and having a discussion with the kid and his coach and all that comes in. But I think that's where I'd have to start. So I'm not jumping to an MFC, if that's your question.
I would say I totally agree with you. Looking at your sagittal, you can see that significant humpback deformity that's forming there. And so I'd be really concerned about that and needing to jack that open and put something structural in there to hold it with good fixation. The question, I agree, is AVN of the proximal pole, whether you have that or not. And so how to go about determining that, a lot of times we get an MRI, which hasn't been necessarily proven to demonstrate definitively whether AVN exists or not. So, I'm interested to see what was done.
I think one key point that Dr. Deal mentioned is that there's there's an article in the literature that we reference frequently that even in cases of AVN or early AVN, you can get these fractures to heal if you correct the humpback deformity. And frequently, if you're doing a dorsal vascularized bone graft, it's hard to correct that humpback deformity. So doing volar vascularized bone grafts, and everyone understands the humpback deformity. The reason Dr. Freilich put a peanut on the first slide is the scaphoid shaped like a peanut. And when there's a fracture non-union, the scaphoid collapses. And this is Greg Degman falling over the radioscaphocapitate ligament when he's describing scaphoid non-unions. But you have to jack it back up to get its normal architecture. And if you can do that, you'll be much more successful in healing these. And residents, remember, if these don't heal, and this is an 18-year-old, what ends up being the end result if this doesn't work? Tim? Yeah, so scaphoid non-union advanced collapse, which is an arthritic condition in a young individual, right? So getting these to heal is absolutely critical, and making sure you address the issues that could lead to a failure in your reconstruction is important. And recognizing the humpback and correcting that is crucial for healing.
Choice of graft.
So I think it depends on what you have in your bag. If you're someone who does free grafts, then that's viable and on the table. You can do cancellous and cortical only. If you want to do a pedicled volar, you can use the pronator flap for that, and it works pretty well. I would definitely go volar no matter what, though.
So I included this for the controversy a little bit, but I think the key is that you have to get rid of the humpback. And then the decision point is also the discussion with the patient. If you put in a screw and you jack it out and you fix it and it doesn't heal, then you have potentially a destroyed scaphoid, a big hole in it, and you have to decide what to do with it at that point. And ultimately, this person ended up getting an MFC, so a knee graft for the AVN, and significant loss of bone. You can see how much bone ends up in there after you jack this out and reduce the humpback, and went on to union. You can see at this point.
So Aaron Freelick and our other hand partner, Brent DeGeorge for Plastics Hand, they've developed a very robust service, the medial femoral condyle vascularized free bone grafts, or medial trochlear vascularized free bone grafts. But they're doing probably some of the most, I'd say, close to the country now. I mean, you're doing a couple a month. So we have a huge series, and this was started by Aaron and Brent maybe 4 or 5 years ago.
Yeah, 3 years ago.
3 years ago. So it's a very powerful way to treat this very difficult problem. But, again, some would say that this was aggressive. So I would say go volar and put in 2 screws, non-vascularized as the initial. But, if you can do this and get outcomes of healing, and it doesn't compromise motion too much, then I think it's a home run with one operation, but it's a big operation.
Aaron, what kind of time, what's y'all's time now for how long it's taking you to do these with the two of you doing it together?
It's probably, with 2 teams operating simultaneously, probably 4-ish hours, 4.5 hours, start to finish, including the micro. So it's become a little bit more efficient, assuming we start on time and everything else. But depends on the case, and depends on how difficult and whether there's a screw that has to be taken out or not. But either end to end into the volar branch if it's big enough, or more commonly end to side. We've been doing it in the main hospital. Maybe we can do it here. Keep them overnight. I can take one up for the better part of the day. It sounds fine. That's a good question. I think I don't know the answer to that. I think we'll have to look back and see what ends up happening. It's not a perfect fit. You can't take enough bone to make the exact sort of shape of it. And to some degree, you don't want to, because you end up with cancellous graft along some articular surfaces, depending on how you put the graft in. But it would be interesting to see over time if there is hypertrophy, if it sort of fills a space, if there's heterotopic bone formation or something like that. Interesting.
But these grafts always hypertrophy. So that's what you want, right? They're vascularized, and when you load the wrist, they're going to hypertrophy if they're truly a live bone graft. So,
good point. Yeah. All right, we'll move on to the next. This was another example. So somewhere in between. So again, sort of beginning to be a non-union. You can see the humpback, but different approach where they ended up with a non-vascularized bone graft and a screw as well. So different approach to a similar problem, maybe not quite as much in the order of AVN. All right. So any other comments about scaphoids? All right. We're going to move on to metacarpals next, which are fairly common injuries in all comers. So first one's 21-year-old football player, linebacker, contact injury with this as the injury. So approach this kind of fracture. Cole, start us.
Yeah, this is my patient just from a few weeks ago. So, it's a shortened, unstable fracture pattern involving the proximal third. Even 2 millimeters of shortening leads to a 7-degree extensor lag. And it also, the moment arm for your intrinsic muscles are compromised with shortening. So it affects your grip. So in those scenarios, a lot of these people, you would say, okay, there's no rotational deformity, but there is shortening. Can you treat this non-operatively? But again, this is a high-level athlete, and in my hands, I would treat this surgically. And because it's a proximal third, I would plate it. I wouldn't do just screws in a linebacker football because you're going to break through the screws. And the one thing I learned quickly when I started practice and taking care of football players, if I did a short segment plate, they go back to contact. You have a stress riser at the end of your plate, so you're going to break distal to your plate. So I spanned the entire metacarpal for these fractures in contact sports to avoid that issue. And the goal here is rigid fixation. I don't even splint their finger coming out of the OR. I put them in a wrist splint and I have them move immediately so to avoid any tendon adhesions. And again, this is a proximal third fracture. So I think plating in a contact sport, I think it's the best way to treat it.
Maybe if this wasn't a contact athlete, either just a regular person who works or a non-contact athlete,
Yeah.
same treatment, something different.
That's what I would, so in my clinic, I don't see these guys, the football linebackers that are playing, I'm seeing, mom or grandma or, whoever fell down the steps and has this, that's a different population. So, it is an unstable fracture, as Bobby said. So you have to really watch out for shortening, angulation, and do something where they can be moving their fingers. But in a regular patient, I would frequently try to treat this non-operatively. So.
And that's, I think, probably most hand surgeons would do that. And again, it's patient specific and what expectations are.
It highlights the difference, different patient populations.
I have a question though for contact, sport, but they're in the off season and they're not going to put contact on it. Do you have to plate them or can you?
Yeah, I had this for our starting nose guard who, it was the spring game. This was years ago and I put a short segment plate on him. And then, 6 months later during the season, they fractured distal to the plate. I think screws are a even higher risk. I think screws tend to create more stress if you put 3 interfrag screws. I think it works in phalanges, but I think in metacarpals, I think in a contact sport, I think it's too risky.
So I will slightly deviate from that. I think in the off season, I treat the fracture based on the fracture. So long oblique. I think screws are fine. I think the problem with it, a big plate is obviously tendon adhesion. I've had to go back in season. I agree with the big plate. And even with that, you have to go. I'm doing one next week where I'm doing a tenolysis because I plated somebody in season, and you treat them protect them as much as you can, and they get stuck. So obviously, intramedullary changes that. I think we'll talk a little bit more about that, but you have to treat it based on the fracture.
So this is what this patient got. So you can see pretty long plate, about as far as you can possibly get, protecting the entire metacarpal, hopefully prevent periprosthetic fracture.
This is a Chabra special. I mean, Deduct sees this all the time, and I just make them all bionic. That's that helps me sleep at night.
Also, if you can't see the bone anymore.
And you got to rehab them fast. Those are all cortical screws, not locking screws, buddy.
You have to tenolyse them.
Mhm.
Do you worry then when you've spanned them and everything about then they go back into the season after you tenolyse them?
I would never take these plates out. They have to be done their career before I take their plate out. Otherwise, they're going to fracture through any of those screw holes.
All right. So second case, so this is a 36-year-old. So not a college athlete, but still active person. This injury, so 2 metacarpals this time.
Well,
I think if it was a single small finger, you could try and treat them in a cast, but I think with this one, 2 adjacent fingers, it's operative. I like the idea of intramedullary fixation. You have to be careful on the ring because it is smaller than the small finger. So you have to use a little bit smaller screw. On the small finger, you can use a 4/0 screw just fine. The ring, you have to go a little smaller, but I like IM. I mean, you could do an open procedure and double plate them, and that's what we used to do. But that distal portion of the small finger, you can get close to intra-articular with the plate and probably do a T plate. So I like IM screws for this.
Any other comments? So that's what this person got. So IM screws. So through a retrograde IM screw for each one. So more stability for the more unstable fractures. but still early return to motion.
So this is actually becoming more and more popular in the athlete for mid shaft or you don't. It's not ideal for unstable fracture patterns that can shorten, but this is becoming more and more popular for early return to play, and we're starting to see some literature for this in high profile athletes. Casey, you have a story, right?
Yeah.
On one.
Well, not metacarpals, but I think one of the Denver hockey players got a metacarpal, but the one I did was for one of the players last year during the Stanley Cup finals, and we did a phalanx and did crossed nails, and he was back playing, in 2 weeks. I think it was right at the end of the playoff, like the first round of the playoffs, and then went into the Stanley Cup finals. And we treated multiple phalanx fractures and then a metacarpal fracture with nails, and it gets them back in. And I mean, I think that that's really the telling thing about all of these nails. And I think the biggest concern going into this is, well, are we going to cause arthrosis? And one of the big arguments is, well, we go through the cartilage all the time. And if you go back about 3 cases, you saw scaphoids get nails through the screws through the cartilage. And that's what we're doing here is we're essentially going through a non-articular block of cartilage. So I think that this is going to be kind of the next wave, and we're going to see complications from it just like we do with plates, but this is pretty huge in getting people moving again.
And less worry for tendon adhesions. Mac. Yeah. I'd love to hear Dave's comments on this. My brother went through one of these at Arizona State, his team doc, and it can be tough when the university says, okay, it's the doctor, not the university. So, we have our standard Piedmont Liability Trust, our malpractice insurance, which is excellent. But I don't think we have anything in addition for our university athletes. Now, I do some consulting for the NBA, and before I was allowed to do that, I had to increase my malpractice insurance at our PLT before they would allow me to do that. So I know there are ways to counter that. But Dave, do you know of anything? We don't have anything, right? Yeah. Weiss. Yeah. So you have a specific malpractice protection that the university signed off on for your Albany athletes. Yeah. The malpractice cap. Yeah. I don't think we have that.
Important thing is if you are doing something that's remotely against standard of care, which is most of the times with an athlete in season, you have to document it. I document discussion that, I've had football players go back 2 weeks out who play wide receiver with phalanx fractures. And I'm like, this might not work, but you're late in the season. Okay, well, we can fix it later.
National championship game.
Yeah. So you have those discussions, I think, and that's somewhat protective. I don't know how much, but it's important to have that, and not just with the athlete and the trainer, but with the parents. Because a lot of times the parents aren't involved until like something goes wrong, and then the parents like all of a sudden are really involved. And so the trainer a lot of times will dictate a lot of the patterns. The players do whatever the trainers say a lot of times, and so you have to have that conversation with them as well. So.
Let's go with less articular. So
Dorsal.
it's the dorsal third of the articular surface. So just don't do a lot of hyperextension. Yeah. So it's still articular. Here's an article. There's a bunch of new articles that come out in the last year or so also that are sort of systematic reviews showing that results are pretty good, and complications are kind of in the 3-ish% range, in line with most other types of fixation. There's just another example here, but this time a boxer's fracture, and then also got a screw. So again, you can do it all the way through box fractures if there's enough stability for length.
A lot of us would have treated that non-op, right?
Yep.
Yeah, this was a nurse who was trying to get back to work, obviously. But you know, I think this scenario couldn't be in a cast for an extended period of time, and so that's kind of what we did. And I used perk reduction, hooks and clamps and things like that. But no, I think it went well. She was moving within 3 weeks. She was back to work in 2.5 weeks. So it's hard to beat that.
Good. All right. Move on to the next topic. All right. So another thing that we treat elbows now. So a lot of athletes, obviously the throwing athlete, big deal. So let's see here. So 19-year-old pitcher, UCL tear. Here's the MRI. You can see the distal tear. So kind of lifted off and probably full thickness all the way through. All right. Treatment options.
Yeah. So Dr. Dacus and I is a big part of our practice, and it's one of the most challenging parts of our practice because those of you who've read that book, The $1 Million Arm, every pitcher you have, even starting at the age of 6, are going to make, $50 million contract. And even if they're not any good, it's just really difficult. Partial UCLs are some of the most challenging to treat as to can you treat them conservatively and get them back to pitching at a high level. And those who have high expectations to pitch and potentially pitch at the next level, I think, that was a pretty high grade tear, and, high grade tear or complete tear should have surgery if they're going to return to pitching. And you can do an acute repair with an internal brace, which has some popularity, but has not been compared to the reconstruction, which is the gold standard. And in my hands, this would get a reconstruction, and I'd augment it with an internal brace, but I'd do a reconstruction with a palmaris or hamstring autograft. And then, rehab for this is pretty clear. I mean, and this is Beamer Carr's article. Beamer, you're here. So, the return from acute repair is, 6 to 8 months for a UCL reconstruction, a high school or college athlete, maybe 12 to 15 months, and then a professional athlete, maybe 15 to 18 months. So it's a long recovery, and expectations are high. But remember, if you look at the literature, world's literature on this, and Andrew's literature, and about 80% of people actually return to the level of playing that they were prior to their injury. So 20% do not. But the expectation is, and the myth is, that they're going to be faster and stronger. And if they threw 80 miles an hour before, they're going to throw them 95 miles an hour after their surgery. And that's not true at all. But that's the expectation that everyone has who wants this surgery or needs or has this surgery.
Same graft choices.
So I'm a little different. I use palmaris, and I'll even use contralateral palmaris, just because I graft size differently than hamstring, and Charbel likes to go to the leg. I do tunnels and internal brace. This age group is very common that we see. Taking care of college athletics, 18, freshman year, probably the most common group that we see at UCL. Pitchers number 1, catchers number 2, outfield number 3. The majority of these kids have had elbow pain at some point in time before. We pre-screen, so if they've come in to college and had an MRI at some point in time in high school, they're at high risk of having a full tear at some point in time in college, and that's kind of played itself out. JMU unfortunately led the nation in UCL reconstructions for 2 straight years, so had my share of that. I think the idea of repair and internal brace for a partial injury in someone who needs to get back for their last season makes a lot of sense. For an 18-year-old, I think we throw everything at them. What you hear a lot of times is that they haven't had pain. They've had pain since they were 12 or 13, but they just were better than other kids, and so they're able to play through it. And so after surgery, it's very rewarding. That being said, it's humbling because a lot of these kids don't go pro. So you feel great about it that they're better, and they come back and their arm doesn't hurt. But I had a kid who started against Florida State, and he didn't make it out of the first inning. And we were so excited. He was like, my arm felt fine, but my brain wasn't there. And so it takes you 2 years a lot of times to get back to your pitching after surgery, even though your arm's better. So this is a long kind of process for kids. It's not easy.
Both. I do both sides.
Yes. Not that we know of. So I tie the graft first so that the brace doesn't stress shield the graft. So I tie the graft as tight as possible, and then the brace is just on top after the fact.
It's just an augment.
No, just I pass it separate and tie it separate.
So one thing about looking at Major League Baseball data, that a pitcher who's had one UCL reconstruction, there's a high chance they'll rupture within 7 years and need a second. And if you have a second, the chance of return is pretty low to the level they were playing. So if you look at a lot of these contracts for pitchers, they're all less than 7 years for that reason, who have had previous UCL injuries. So it's not uncommon for these pitchers who make it to the next level to rupture their UCL again.
I think we all move the nerve. Everyone here moves the nerve.
Anybody else that fixes UCLs in the room? Move the nerve every time, some of the time? Never.
There's a lot of debate about that. And if you look at the literature, the number one reason for take back is ulnar nerve symptoms. And the hand surgery literature has a difference. So if you're a hand surgeon and you transpose the ulnar nerve and not scared of the ulnar nerve, it's not a big deal for us to do it. But every sports surgeon who does it, you know, the reason I get to do butt surgery with Winston Bothamy to repair proximal hamstring tears is because he's scared of the sciatic nerve. So I get to hang out with him doing butt surgery. I'm like, I'm so scared. I'm scared of how big it is. And I'm looking at it through loops. I'm like, I can take my loops off.
So fixed here with a palmaris graft reconstruction and ulnar nerve transposition, and this one got tunnels and an internal brace. You can see the suture over the top of it, lending sort of instant stability and hopefully protecting the graft while it heals. I think we've run out of time here, so this is just another discussion and just another way of doing it. So still can do it with docking technique without an internal brace as an option. You can see the return to play is at 12 months post-op. So long slog to get back. All right.
Good.
I think we'll call it quits there. Keep us on time. All right.
Thanks, sir. Where do we put these?
Here, give me, I don't know what your name is. Yeah.